oximeter does. You have an emitter and a detector, and you've got a red over infrared light that's shining through the nail bed, and based on the reflection and absorption, it's going to give you a reading of SpO2, and it's also going to give you a pulse rate. But the SpO2 is going to be looking at total hemoglobin. It doesn't know if there's a dishemoglobin that's attached to that hemoglobin molecule, so the patient will present bright red. It'll have normal sats. However, what's being transferred to the tissue is less than optimal. And so we're going to talk about some of the problems, and you probably will chime in and say, yeah, that happens all the time type of thing. And that's me. Nice place to be. But okay, so the first thing we're going to talk about is, and we're going to just blast through there. You know, when you take a breath, that oxygen gets transferred through gas exchange, and then obviously the blood's carrying the hemoglobin. The hemoglobin with the oxygen is transferring to the tissues. That's all good stuff, generating energy and making life beautiful. And of course, because SpO2 is looking for an arterial pulse, all of our patients, regardless of what their status is, if they don't have a discernible arterial pulse, you will not get pulse oximetry. You will not get co-oximetry. So, you know, we know that the SpO2 is a total amount of HB bound to something. We don't know what that something is. What it's not going to tell you is what that something is, and you obviously need to also look at signs and symptoms. What you'll find with CO exposure is the signs don't always correlate. So the way pulse oximetry works, it bangs through and it uses two wavelengths of light, and based on an algorithm that's been established, we're able to measure what the actual sat is. There are some problems with that, and of course these are normal numbers until we get into this range, and then we have to consider high flow oxygen. But the problems, and you've probably seen these fingertip thingies at Walgreens for $39, they were not designed for you and me. They were designed, well, they were designed for you and me, healthy people, but the people that we're responding to, whether they are walk-in or transport or at the scene where the medics are first doing their assessment, they're shivering, they have poor peripheral perfusion, and they may have a dishemoglobin, and so pulse ox goes right out the window. And I will tell you, if I took a non-Massimo pulse ox, whether it's a Nonin, GE Tough Sat, or any of those, and I do this while I'm doing this on the other hand with mine, I'll get a reading. Those will freeze, and I'll explain how the other ones work and why we actually were able to do some incredible things, and this is how Massimo became who we are. We all agree that arterial pulsing is what we're using to measure pulse oximetry, but in that whole thing, we've got venous return, we've got shaking, we've got low perfusion. And because of that, just like when we've got ECG monitors, if the size is set way too low, we pick up artifact, we pick up PVCs, and so the actual heart rate's 60, but the monitor's saying 100. We always want to treat the patient, not the monitor. The problem with that is, what's the true heart rate? Now, you will get the true heart rate off a pulse ox because every time you contract, it's going to read that, versus an electrical, which could have interference. So what we did is we digitized the front end from here to the machine so that we are able to squash things like motion, low perfusion. We did that by actually putting in discrete filters called parallel filters. And by the time the signal gets to our machine, it is the arterial pulse, not noise, not artifact, not all the stuff that could corrupt the signal and give you a inaccurate reading. Now, where inaccuracies make the most difference is at our NIC units. First of all, we know in a NIC unit we have to titrate oxygen very carefully, or we have the potential for retinopathy. The other thing is, and if you've worked in a NIC unit or in an area where you've got little kids flailing all day long, what do the monitors do? They alarm, because all that artifact's causing noise. The noise is either averaging out the display so that it's giving a blank, or the unit's not showing the desaturation because it's all over the place. So what do we do as human beings? We hear a lot of noise in the background. We're covering 4 beds. we start hitting pause, pause, pause. Now a true alarm comes in and it's missed. Patient desats, you've just paused it because it's been driving you crazy for 6 hours. The patient dies. So Masimo, when they developed SET technology, which is an acronym for signal extraction, we are the only company in the planet that can do the impossible, which is read through low perfusion. And hopefully your new GE monitors don't have anything but Masimo SET. You're going to get best in class performance. I can tell you, your LifePak 15s have Masimo SET. And really, when you think about it, the sick people need measuring equipment that can get the job done, because if it doesn't work and you're trying to make critical decisions, life is not so good.
Switch to LifePak 20s on their code cards too. So
Yes. So here's your conventional, all this crap, and then here's what we do. We just squash it all, the signal comes through, we get something really meaningful. Now, this is a very brief overview. I've got other PowerPoints on the thumb drive that I'm going to load in your computer, but here are some of your common signs and symptoms. So now let's talk about a real life situation. I put 4 of these devices in the Rockford Fire Department in Rockford, Illinois. And I always call my customers a few months, a year after. How's it going? What you been doing? He says, it's funny you called, because 2 months ago we responded to the high school. Kid was acting really bizarre. He also had a very recent head injury. So now you're doing the prudent thing, Mr. Paramedic, and you're saying, I'm going to take you to the hospital and do a little assessment, maybe an MRI. Who the hell knows? He might have some intracranial pressure increases and maybe oxygen. We don't want to consider that for that particular situation. While they were assessing his vitals, this thing alarmed at 20%. Now understand that if the SpO2 is 95 on the monitor and the patient is 20% exposed, you subtract the exposure from the actual total number, and that's your true SpO2. So in that particular setting, we're at 75%, and by clinical definition, that patient's hypoxic and needs high flow oxygen. But in the case of this kid, when they realized he had severe exposure, they started treating, which is key. Early intervention, because the half-life of CO on room air is 4 to 6 hours. Add supplemental oxygen, you'll bang it up down to an hour. Put that same patient in a hyperbaric chamber, and you'll flush them in a half an hour. And where it's most important to consider a hyperbaric chamber is on pregnant females, because although we can flush mom with high flow oxygen, it does not transcend through the placental wall, and the only way to do that is under pressure. Okay? So in this case, when the mom came into the ED, she measured 15%. Now, all of us in this room are now suspecting there's an exposure. Wasn't at the high school, because mom didn't work at the high school. The home. The medics circled back to the home, found that the apartment next to him had a CO leak. The furnace, it was in a vacant apartment, and the furnace had the flue that wasn't doing its job. Now, this saved a life. You would have withheld oxygen until you figured out, if you really had a bad head injury, what the next step was. Yet this kid really needed it. So the exposure didn't even happen where they responded to. They can walk in with their 4 gas analyzers, which they'll do if they suspect a call. The other side of it, and I hope these guys are doing this, is when they walk into on a shortness of breath call, they don't know if the area is toxic unless they have a single gas analyzer they've clipped onto their first intake. I hope they have such a device. If they don't, they're $150. I bought one for myself. I stayed at a lot of hotels. A lot of people have been dying in hotels recently. They sent 40 people from the Baraboo area because the ice rink, the old style ice rinks, were gas powered to freeze them, and they had a CO leak. I mean, I get Google alerts daily. You'd be surprised. Stupid, running gas generators in your basement? Are you kidding me? Barbecuing in your garage? Understand about CO, if we put CO, fill this room with CO and seal this room off, it would get throughout the entire house. It permeates through drywall, through cinder block. The only way to get rid of CO is to ventilate the area. The only way to reverse the damage, at least, is whatever you can do initially, is high flow oxygen. So it is the leading cause of problems in industrialized countries. People don't realize forklifts generate CO. I was at the American Heart Conference a few weeks ago, and I was at McCormick Place, 100-foot ceilings, but forklifts were running around while we were setting up, and my little single gas analyzer was reading 10 parts per million, which is well under the standard, because if you've got a CO monitor at your home, you've got to get one. If you don't, put it near the living area, and they are set up, they're time averaged, and they also look at parts per million of 35 or greater, which is not lethal, but low exposures, chronic low exposures to CO is as bad as one big one, okay? And so you and I aren't exposed like the guys who are running. I mean, think about this. Well, we're smart enough to run away from the fire, they're running into it. And when they run into it, when UL did studies of all they did what's called a smoke characterization study, they found that there was hundreds of different chemical asphyxiants in smoke. But in every one of those things they burned, CO was there every time. Now, when it really gets bad is when it's hydrogen cyanide, because that'll knock you out and kill you real fast. Hydrogen sulfide's got that stinky egg smell, which is great because your senses, before they get overwhelmed, you know something's wrong. But cyanide, bad stuff. So about 35% of the work-related injuries are related to CO. I was at a small township in western Wisconsin, and I always test everybody, and this kid came up 8%. Now, there's an accuracy flip, but this is a non-smoker, and traditionally smokers will have 5 to 10%. I said, what do you do for a living? You don't smoke, you're 28 years old, you seem like you're in good shape. He says, oh, I drive a forklift. I said, have they been keeping those bay doors? Nah, it got cold, they closed them. The overhead's going to read at 35. This kid's sniffing in. Maybe he's getting a headache or he's getting a little lightheaded. He doesn't know because you can't smell it. You can't taste it. You can't see it. I'm preaching to the choir. But I like to make my point. Now, what you need to know from a chemistry standpoint, the vapor density is lighter than air. Therefore, it has an affinity to attach to the hemoglobin molecule. That's good and bad, because then instead of delivering 100% oxygen in the tissues, whatever that dyshemoglobin, how big it is, will block the amount of oxygen that can be transferred, and then we end up with hopefully some signs and symptoms, but don't always expect that. Here are some of your common sources. I mean, come on. Forklifts are right up there. Smokers traditionally will have like 5 to 10%, but you've got floor buffers, water heaters, you've got furnaces, gas stoves, compressors, and then if you've got
recent house fires.
Oh yeah, and then of course with house fires, this is what gets me. They banned asbestos. This was a good thing because we know that causes carcinogens. If you took the glue that's binding this carpet to the concrete and ignited it at 400 degrees, it would off-gas hydrogen cyanide. This is all like PVC and crap. And so I'm wondering, when they tell you to drop, rock and roll, or whatever, and you get on your group, and that thing's leaching up cyanide, I don't think that's going to be too good either. And I don't think we're going to have air packs anytime soon in our house. Grab the air pack! But so about how it transfers. Here's the neurological. It could create things like confusion and it could alter the brain, and when it does, if it's a firefighter and he's gowning up again to go back after he's burnt his first air pack and he's slightly exposed, this is not someone you want to work with. This person's going to make stupid decisions, and if this person hasn't properly hydrated, they're going to be mush in a very short period of time. And what a lot of fire departments are doing is they're putting peak charts over their urinals. Obviously, they can test real quickly if they're dehydrated or not, and they should always carry water on them before they even get going, because it literally only takes an air pack, and you've lost almost a liter of fluid. Now, that doesn't mean anything to these kids as much. They'll get some muscle atrophy, but you and I, we lose a liter of fluid, our pH goes off the charts. We had a little problem with our heart, with some fluttering, then all of a sudden, boom, we go down. And that's why rehab, and hopefully your EMS team, is going to develop a program that'll make it so these firefighters are safe, because really, at the end of the day, they're in the worst situation. But as dangerous as the fire ground is, it's the heart that gets most affected to these guys, because this is like a marathon. This is like Iron Man 3. I mean, it's what they do is so strenuous, and it is a young man's job. It absolutely is. Cardiac, we could get arrhythmias at higher types of exposures, but you know, think about this. Over the years, you provide less than optimal tissue oxygenation. Tissues die, brain dies, heart gets affected, and you go through an entire career. And if you've noticed, if you look at some of the statistics, firefighters, career firefighters, not in the town of Osage, but the town of Chicago, or Milwaukee, or Minneapolis, if they work an entire career, 25, 30 years, the average lifespan's 5 years. That's not good. You know, I don't begrudge any of these guys getting a pension. I would never not pay them for what they do. The public safety is an incredible asset, and we appreciate it because we're in this business. The lay people just complain because their taxes have gone up, but I'll pay their pensions for the rest of my life. I don't begrudge them, but everybody needs to go home all the time in one piece. So here are your signs and symptoms. So I walk in, Jill, and I say, I'm not really feeling good, and I'm a little bit disoriented, and I'm short of breath, and you're thinking, do you have any history of heart? What kind of medications you're on? Oh, you're a diabetic and you've had CHO. Okay, we're starting to put together a piece, because the best clinical people I know are the people that can take every data point and create kind of like a story so that we can make an intelligent clinical decision that's going to have a positive impact. This is what we're in here for, hopefully. We make mistakes, and sometimes we miss it, because any one of these could be a number of problems, and we don't know until we test for it and rule it out. So your treatment considerations, 100% oxygen. Got to know high flow oxygen is absolutely positively great. Now you have an SpO2 SPCO assessment guide, and we're going to open it to that, and we're going to keep that in there. Yeah, I don't expect people to have to open this up to figure out the device. So you're going to look at this chart. The chart pretty much shows you what the exposures mean, and it really isn't until we get into the 10+% that we need to be concerned. But let's talk about accuracy, because I know that that's an important thing for you guys. When we did the specifications, we did the specifications based on some chemistry analyzers. I will tell you, if you had an iStat, you know what an iStat is, 2 of them next to one another, and you calibrated both of them, you get 2 different readings. They're close, but they may be off 1 gram per deciliter, or they may be off so many percentage on the hematocrit. It's, you know, it's not a perfect science. Now, with pulse ox, we had that red over infrared. We could do just about anything. Jumping jacks, it'll read. When we want to read CO, remember now that we developed a technology called Rainbow, where instead of shining just 1, 2 lights through here, we're shining 7+ lights. Those lights are in the infrared and the visible spectrum. Therefore, we put shutters on here, because some of the visible spectrum means bright lights, strobing lights, sunlight, if infiltrated through here, could create a false reading. So we need to protect ourselves. Now you saw that little boot, that boot cover. We're going to give you something better, because I don't want you to do that, because one of the things is you're going to look, there's a black stop, you want the finger to go all the way to the stop, and then wire over the top, right? And then this goes over here, and then we sit still. Because in the first 30 seconds, it's going to read the arterial pulse, and it'll give you immediate pulse ox and heart rate. It may take up to 120 seconds to read the SPCO, because we're digging deeper at the molecular level to look at percentage. With that being said, we quote a ±3% accuracy on that, whatever that display is, based on 1 standard deviation. So now let's go into what's the standard deviation. 68% of the population will fall between plus or minus 3% from 1 to 40% displayed. Let's tighten it up. It means 2 out of 3. What about the other 1 out of 3? So let's go to 2 standard deviations. That would cover 95% of the population. Downward plus or minus